Good afternoon, everyone. Thank you so much for joining today's Dent Echo. I would like to start off by letting everyone know that this session is being recorded. These recordings will become available on our Dent Echo website after the session. We are very happy to have you all join us for the 25th Dental Education Network for Texas Echo, commonly known as the Dent Echo. This session is brought to you by the UT Health San Antonio School of Dentistry. My name is Angela Riley, and I will assist in facilitating today's session. Taylor will be our wonderful IT support for this session as well. Next slide, please. If you haven't already, please complete the pre-session survey using the link in the chat. Taylor shared that not too long ago. Next slide, please. So here we have a brief overview of today's session. We will begin with some housekeeping and introductions. Then we will move on to our didactic presentation by Dr. Myra Hister-Cockrell, followed by the case presentation from Dr. Tiffany Tavares, with time for Q&A towards the end of the session. Some housekeeping items before we begin officially. As mentioned earlier, these sessions will be recorded for later distribution on our Denteco website, and the slides will also be shared on the website for reference. Please remember to stay muted unless you are speaking. We do encourage using the chat and/or raise your hand feature to share questions and your perspectives after our didactic and case presentation. To help us with attendance, please do enter your name, affiliation, and email into the chat. And please remember that no personal health information is allowed either the chat or our discussion today. And if you would like assistance with your connection or have any tech issues, please privately chat Taylor, our Echo IT. So for those of you who may be new to our Echo, we welcome you to this space. We're happy to have you. This is a model that builds virtual communities of practice and learning. Sessions include a brief didactic presentation followed by a de-identified case-based learning and group discussion to foster deep knowledge and build individual capacity. Echo is an all teach, all learn supportive model, and Echoes thrive on the interaction from the full learning network, which is you all, our participants. So we do encourage everyone to participate in the conversation today. Next slide, please. To receive CDE credits, please make sure to be on the session throughout the duration of the presentation. If you would like to receive CDE credits, make sure to register through SMILE, which you can do so now using the link in the chat or by scanning the QR code that is on the screen. When registering, please use the supercode ECHO 2025. We will leave this slide up while we do team introductions, followed by our presenter introductions. So let me check here real quick who is on. I will start with Dr. Dar. If you could please introduce yourself and move on to presenter introductions.
Absolutely. Thank you so much, Angela. Brief introduction about the Dent Echo Hub team. The Dent Echo Hub team has Dr. Chala, who is our program director, Dr. Marwaha, Dr. Urankar, and the team. And I am also part of the team. I am Dr. Shohini Dhar, assistant professor with the Department of Comprehensive Dentistry. And it's my utmost pleasure today to introduce our two esteemed speakers, Dr. Hister-Cockrell and Dr. Tavares. Very dear colleagues, and it's such a pleasure having you both here. Thank you for your time and sharing your expertise with us. Dr. Hister-Cockrell is an associate professor, clinical, with the Department of Comprehensive Dentistry at our school. She is the operative course director for first and second year dental students and clinical faculty for third and fourth year dental students. She is also a fellow of the Academy of Dentistry International. Dr. Hister-Cockrell received her DDS, an orthodontic certificate from Brazil. She received training in advanced education in general dentistry and implantology at Baylor College of Dentistry, where she was also a faculty member. Thank you so much, Dr. Hister-Cockrell.
Thank you.
For our case presentation, we have Dr. Tavares. Dr. Tiffany Tavares is a clinical assistant professor of oral medicine in the Department of Comprehensive Dentistry at our university. Dr. Tavares received her dental degree from Brazil and later completed oral medicine residency program and received a Doctor of Medical Sciences degree from Harvard School of Dental Medicine. Dr. Tavares is a diplomat of the American Board of Oral Medicine and greatly involved in the activities of American Academy of Oral Medicine. Welcome, Dr. Tavares. Over to both of you to take it forward. Thank you again.
Thank you. All right. Share. All right, Doctor, can you guys see me well?
Yes,
Angela?
that looks great.
Yes. All right. Thanks for having us here today. It's a big honor for me to be here, and I hope I can just share with you what I've learned throughout this very deep study that I have been doing. Let me just get our time going here. So the impact of hormonal fluctuation on women's oral health. So the objectives here, let me just move you guys a little over there. So the objectives is to create an awareness for our viewers about the hormonal changes in a woman's life and to educate the audience of the options that we have for treatment, where to find help when need to improve oral health. Thank you, Dr. Dar, for all the introduction, so everybody knows who I am. So let's see how this started. It was an invitation to write this first article here. Oh, let me get the little laser pointer. This first article here, the hormone fluctuation in women's oral health, it was published here in our school. After that, I got an invitation from Laura Unger. Let me just say, this first article here, I had a huge contribution from Kristen Zapata, which is our reporter here at the UTASCA. She did an amazing job. We worked for a long time, so it came out really well. And then I got a email from Laura Unger, which is from the Associated Press, and she's doing a project about, it was pretty big actually, menopause can bring on dental problems, but you can protect your mouth. So these on the Associated Press, I work on my part of the article with Aline Teves, and both of these articles was overseen by Jackie Saha, which is the director of marketing here. So I don't take any full credit for anything because it's just always been a teamwork. So I'm very, very happy to have everybody with me. So when this project happened, I ended up getting another email, and it was in a lot of places in the United States. So I just got my paper here. So through this article, we end up in Minneapolis, Detroit, Atlanta, Nevada, Athens, North Carolina, New York. Laura Unger is from New York as well. So it has been a topic that is getting a lot of attention lately, and I don't know why, but it's just happened. And somehow this first article here was it was how everything started. I do have some information from Dental Tribune. That is an email that I got, and I don't know if you guys can see, I just printed out. That is the new magazine, that is a cosmetic dentistry magazine. And here it is, the hormone changes in the periodontal health. So this is a 2025 article, just came out. So again, that is more to read about it. Okay, let's talk about the hormones. Can we put this over here so I don't know if they're so we'll be able to see here. I have Dr. Tavares here in the room with me. There you go. That's better. Thank you. So the hormones, what do we have to say about this? Chemical messengers hold the power to regulate mood, energy levels, sleep, appetite, and libido. The question is, any changes in oral health when that happen? And the answer is yes. So from puberty to menopause, a woman's entire body, including her mouth, is impacted by the rise and fall of hormones. So I put this graph over here, so women, please don't get terrified, but this is 50 years of age. What happened? Estrogen, progesterone, everything dropped. And, that is 45 to 55 that this can happen, but average, that's what you see. Okay, let's talk. We're going to jump into different stages of this women's, our lives. Let's talk about puberty. So what happened? The increase in hormones triggers the puberty and swells the gums, making them sensitive. They are easily irritated and prone to bleeding. While gums are vulnerable, they are subject to infection by the bacteria that we already have natural in our mouth. So very important to do a good home care, brushing and floss in mouthwashes. Usually around puberty, that's when we take our kiddos and moms to be evaluated by the orthodontist. So and I put this picture here because by having the braces, how hard it is. So if you guys have braces like this one, how difficult it is to clean. So if you don't have a good, movement and a good education on how to do it, these teenagers have the gums like very inflamed and very infected. So having a diligent routine, it's important too. And of course, a healthy, balanced diet. Another point I'm gonna say here is that when you're the female, we're just talking about females here, when they're younger, so the parents can plan their meals, what they takes to the school, what to eat. So at night, we usually check, did you brush your teeth? Let me see if you floss, so you help your child. In a puberty, parents leave the teenagers a little bit more, give them freedom. No, it's hard to go and check. Let me see if you check your teeth. So this doesn't happen. So very important for you guys that have young patients, to make sure this is really point out to them. So the impacts of birth control in pregnancy. So individuals on birth control or pregnant find themselves in the same side of the two sides of the same coin. For both, hormones levels are similar. So contraceptive mimic the stages of pregnancy. So you have a higher level of progesterone and estrogen. So this surge makes a woman vulnerable to bacterial colonization and gingivitis. So 60 to 75% of pregnant women have gingivitis. Dr. Tavares is going to go over a little bit more in detail. Usually women stop going to the dentist during this time. We're going to talk about that too. So seeing a dentist during the second trimester of pregnancy is highly recommended. Both the American Dental Association, the American College of Obstetricians and Gynecologists have stated that seeing a dentist during pregnancy is safe. The American Academy of Periodontology states that it's safe to receive dental treatment during pregnancy, including SCRPs, the scaling and root planing, non-urgent procedures in the second trimester. So we're talking about 14 to 20 weeks during the pregnancy as is the ideal time. That's what Dr. Kajimoto, our periodontist here at UTASCA, stated. So this presentation, I chose to do interviews to my colleagues here at school. And of course, I couldn't get everybody, but I pick up just a few colleagues. We start with Dr. Dar, presenting on the public health. She introduced herself beautifully already. And she gave me this information here that this article that they observe in 10 states in United States about the disparity in access to oral health care during pregnancy. And I find pretty interesting, actually. So 56 of mothers did not have dental care during their most recent pregnancy. 60% of mothers did not have their teeth clean during the most recent pregnancy. Okay, this is very important. I mean, why not, right? Black non-Hispanic women, 24%, and Hispanic women, 25%, were significantly less likely to have their teeth clean during the pregnancy than the white non-Hispanic women, which is 44%. 59% did not receive any counseling about oral health during the pregnancy. So what is the preventive approaches that will help women to keep mouth and teeth in the best conditions for a lifetime? Attention to the good home care, regular dental visits, good eating habits, limiting sugar and sweetened beverages. This is another article that she sent to me, and it shows that during the pregnancy, women are more likely to be motivated to adopt a healthy behavior. So this part here, I think for my students, thank you for being here today, by the way. I cannot see you all. I did a different screening here. But that's our part. That's the dentist part. Let's just motivate our pregnant patients to keep, coming to the dentist. Counseling about oral health care has been shown to be highly correlated with teeth cleaning during the pregnancy. So bring your patients in, clean their teeth, and just keep educating them. So again, the interprofessional practice between oral health and the obstetric, the OBGYNs to motivate the patients, that really improve the lifelong oral hygiene habits for our patients. Let's go a little further now in the woman's life. Let's talk about menopause. It is notice a reduction in estrogen and progesterone. That's that big drop that I showed in one of the first slides. What happened? Body temperature fluctuates, menstruation comes irregular and then stops. So to really consider a natural menopause is when a woman do not have her period naturally for 12 months. And that occurs sometimes spotting during the time that is more towards perimenopause. So that will happen before, which the woman already start feeling the sleep cycles change and all these feelings that will occur during the menopause. And of course, this is in the oral health. What happened? Bone loss, dry mouth, gum recession, sensitive teeth doing root exposure, etc. A study shows that in average, a woman loses up to 10% of their bone mass in the first 5 years after menopause. I would like to mention something that is called surgical menopause. So in a natural, a woman between 45 to 55 years of age, the perimenopause and the menopause occur, but it can occur very early if a woman it's surgically induced to menopause by removing the ovaries, fallopian tubes, and or the uterus as well. So for some medical condition that needs to be done, a very young woman can have that. So by saying that, when you have your patient in the chair, it's again towards my students, you got medical history is very important. Okay, make sure you know your patient. Very important to me is the perio part as well. So Dr. Kajimoto gave more contribution to our project here, and she highlight that the hormonal changes during puberty, menopause, and contraceptive use can affect the progression of a periodontal disease in a woman with diabetes. I notice in our patients here, population that we have at UTESCA, our students do a great job doing the medical history and presenting for us. So as soon as you see diabetes, we need to diabetes, periodontitis, gingivitis, you know, that should already get a little bit in your head. Because diabetic women with periodontal disease have an increased risk for cardiovascular disease. When together, this risk may be compounded and increase the likelihood of arteriosclerosis, stroke, and other heart-related issues. So what can we do? What can be done? So let's talk about hormone therapy. The hormone therapy can be used in some women, not all of it. If you do the hormone therapy, it's HRT, hormone therapy replacement. So you don't have the estrogen and progesterone, so your doctor start giving you and you take intraorally, can be gel, can be patches. There is several ways that a woman can use, but not all of the women can. Some women cannot even use birth control for some reason, so it depends on their health. So the OBG is the one that is gonna say yes or no. And the research that I did in the literature, there is a lot of pros, you know, it's gonna help the woman with when you are on menopause. If you do hormone replacement therapy, you're gonna have better skin, better hair, hot flashes are decreased, a good night of sleep, which you have during the menopause. So doing the hormone therapy, it will help too. This way will help, and I was going to mention this in geriatric, you don't have much of the periodontal problems as well, so your gum will be healthier. Okay, so this is all the pros. And the cons is if the woman is prone to certain disease, for example, cancer, the hormone therapy may not be a good indication. So your doctor will be the one telling you what to do. Very important here, keep going to the dentist. That's what we are planning for this patient. You're gonna know, let's say you have this patient for 20 years and before she good oral hygiene, everything is good. Now she's on menopause, she has xerostomia, is collecting more plaque, start having pockets that you didn't see before. So you as a dentist will take a look and say, you know, I want to see you in 3 months. I want to see you in 4 months. Hey, we're going to add a couple of other things for you to do at home. So this will be your home care. You know, use this mouthwash, use this medication to maybe increase your saliva. So there is things that we can do. And of course, eat healthy, get enough calcium and vitamin D, be physically active, maintain a healthy weight, don't smoke or use tobacco products. And I will add in here the consumption of alcohol, if it can be limited, that would be very good for the woman in this area. And then I put this picture here on the bottom that I love to see those two ladies that looks to me they're by the beach and having a good laugh. You know, the mental health that we talk a lot about at this time, you know, in our lives. Have a friend. If you have your mom or somebody going through this, it's very important to have a friend that you can say, hey, I'm feeling this. What are you doing? Where are you going? Being outdoors, getting enough sun. So this is a good talk to have with your patients as well. Let's move now to the point of view of a prosthodontist. And I interviewed Dr. Villarreal. She's a clinical associate professor here in our school. I am gladly work with her in Team D and work in the lab as well. So we work very close and it's good to follow up the cases together. So the points that she sees in her clinic and the patients that she sees in our clinic at UTESCA, the salivary changes, the denture fit and function, the craniofacial changes, the implant-related bone loss and exposure. And then what should be looked into the point of a prosthodontist or when you are doing the pros for your patient? The saliva production, so we call xerostomia, right? It causes dry mouth, mucosal irritation, cause denture retention issues. What is the solution? We do have options to give to your patients, the saliva substitutes or stimulants and frequent denture adjustments. This is a pretty interesting picture that she shared about bone health. So you see an acceleration of bone resorption, osteoporosis, the alveolar ridge loss, craniofacial changes. So what is the solution? I always like to ask, okay, what can we do to help our patients? Bone grafts, implant-supported prosthesis. And what are the clinical challenges when you have a patient on this stage of their lives? The denture fit. So you have thinning of the mucosa, bone loss, ill-fitting dentures, discomfort, chewing difficulties. What is the solution? Regular relining, soft liners, or implant-supported options. Craniofacial changes, we see loss of the facial height, lip support, the collapse appearance when the aging start happening. What is the solution? Dentures designed to restore the facial aesthetics. And how about implants? On this picture here, you can see the shade of the implant. See right there? So you already have bone resorption. I don't know the stage of the health of this patient, but you have the increased risk of peri-implant bone loss in implant exposure. Treatment for osteoporosis, including Prolia, can limit the treatment options and make management more complex. So the solution would be peri-implant bone density assessment, bioactive materials, regular monitoring, and medical consult. So in conclusion, the takeaways, we already talked about the hormones, and it can really impact the prosthodontic treatment outcomes. So she mentioned, let's consider salivary changes, tissue and bone loss, craniofacial alterations, do a personalized care. Each patient, treat them individual, regular follow-ups, and with advanced techniques, implant-supported prosthesis, for example. And the final message she would like to share is understanding and addressing these changes. You gotta be educated about those so we can provide a better care and improve the quality of life for our patients. And this is the last part of my presentation. Let's see how we're doing on time. Okay, so I interviewed Dr. Soto, which is the director of geriatric clinic that we have at Itasca. And she shared a couple of her findings in her clinic, like we mentioned about the xerostomia, the dry mouth. With that, you have higher risk of caries, difficulty swallowing and speaking, and the periodontal disease. So you have the estrogen decline leads to bone loss and inflammation, osteoporosis. We're going to have tooth loss, alveolar bone resorption, implant challenges, burning mouth. Dr. Tavares is going to cover that as well, taste alterations, and complication post-extractions. The patients, they don't heal fast, so that is something we need to think about that. And she shared a couple of links, health links, you know, the periodontal with osteoporosis and all that, that is posted over here. This is very touching to me, this slide, because when I talked to her and she gave me this material, I'm like, okay, all this, we're talking about the caregiver or we're talking about the elderly patient? And she put together this slide for us. It's for both. So when I see this, I get a little emotional actually, because, you know, grandparents, elderly parents, you see a lot of neglect of their personal dental care. And I'll give you an example. Let's say you have husband and wife, and the wife is taking care of a husband. She really, it's common to see she'll neglect herself to take care of that husband with his medication, with his doctor appointments, cleaning his mouth, maybe changing diapers, and so on. So it's very common to see. So we need to be, this is a huge awareness for all of us. Financial constraint, yes, insurance don't cover everything. We talk about, you know, treatment with implants and prosthesis and everything. So insurance cost is a concern. mobility issues, the transportation of the patient and stuff. It's a little bit more complicated. And then it does have a psychosocial impact, the self-esteem, the social isolation due to oral discomfort, or they have dangers, they don't want to go out and eat, or they have to take the dangers, they cannot. So let's just be aware of that. So how can we help our geriatric patients? Preventive strategies, fluoride, saliva substitutes, nutritional counseling, treatments, bone density assessments, healing delays, and work the physician with the caregivers, with the dentist. That's an interdisciplinary collaboration. And, be attentive to these cases, I'll say. And this is my last slide. Dental care is healthcare. That's not my phrase. This is one of the research that I was doing, and I love how they say that. So again, I'm leaning towards my students here. And I always, when I have a chance, when I'm teaching, you are not only treating teeth and gums and crown preps and restoration, you're treating a full person. It's a whole human being. So communicating with your patient, communicating with their doctors, make sure that they're taking the right medication. We see a lot of patients with high blood pressure in our clinic. It's amazing. So just treat them as a whole. So remember that the mouth is part of your body. So dental care is a health care. Okay, I have the honor now to introduce Dr. Tavares, and she's gonna sit here to have access to the computer. Thank you. So I cannot see yourself there.
Okay. Hello, everyone. So now in this section of the presentation, we are going to discuss the oral lesions and specific oral disorders that we may encounter in the context of women's health. So we're going to go by stages. In early childhood and adolescence, what we tend to see more often, none of these are exclusive to women, but we may see it, certain presentations of it more often in females. So recurrent aphthostomatitis is a very, very common oral disorder. It's considered an immune-mediated disease from T-cell cytotoxicity. There's increase in inflammatory cytokines like IL-2, IL-6, TNF-alpha. This is not, again, exclusive to women or hormonal fluctuations, but we'll see how this may impact it. There is some genetic predisposition and triggering factors that can bring on a new episode of recurrent aphthostomatitis. And recurrent aphthostomatitis, as the name suggests, is when there are recurrent episodes of these ulcers that are self-limiting, meaning if you just give it time, they will go away on their own, and they typically affect the non-keratinized mucosa. And they can be divided into the minor, the major, or the herpetiform subsets of recurrent aphthostomatitis. The minor being on the non-keratinized mucosa, a few ulcers, just like this one that we're seeing in the photo. The major, as the name suggests, are larger ulcers, usually 1 centimeter or greater. And the herpetiform, also as the name suggests, looks like herpes type ulcers. Has nothing to do with the HSV virus, but they will be small ulcers that can sometimes cluster together, and that's why it's called herpetiform. But again, nothing to do with HSV. Why I'm talking about this is that there are some gender-specific considerations. Although this is a common disorder, in that 20% of the population will have recurrent aphthostomatitis, we tend to see this onset in children and younger adults. And the less common variants, such as the major and the herpetiform variants, tend to be more common in females and more common after puberty. And the thought behind this is that the cyclic fluctuations in estrogen and progesterone increase some of those pro-inflammatory cytokines that I was talking about. And the contraceptives, just as we said, you have contraceptives that can higher doses of estrogen and progesterone that also can increase that pro-inflammatory cytokine expression and lead to the development of recurrent aphthous stomatitis in patients who are already susceptible, already have them. They may have worse presentations during that time of life. So those episodes are going to intensify typically during the luteal phase of the menstrual cycle when we have these surges in hormones. That's when we'll have the most pronounced effect. And we diagnose this based on histology, or not based on the clinical presentation, because the histology is not specific. If you were to take a biopsy of an aphthous ulcer, of recurrent aphthous stomatitis, it will just say it's a non-specific ulcer. So the diagnosis is having multiple ulcers, a non-keratinized mucosa that are self-limiting. This started in childhood or adolescence or as a young adult early on in life. Then we can make a diagnosis of recurrent aphthous stomatitis. Nutritional deficiencies, it's important to screen for them because sometimes when a patient has nutritional deficiencies like anemia, they can also present with ulcers that are aphthous-like. So they look like aphthous ulcers, but it's not actually recurrent aphthous stomatitis. So that's why it's important to screen for those if it doesn't seem like a regular case of RAS. And there are many other disorders that can have aphthous-like ulcerations that we would need to rule out. To manage recurrent aphthous stomatitis, there's not much to do because it will go away on its own. Within 2 weeks, 1 to 2 weeks, these ulcers tend to resolve. But as I just said, the major and herpetiform variants, they tend to be more severe and they can happen in this population that we're talking about. And they may require some treatment. And options are topical anesthetics just to soothe. It's more palliative to give it some time to resolve on its own. But as the major and herpetiform variants can last a long time, maybe impacting patients' ability to eat, you can also give them topical steroids. For very recalcitrant cases, sometimes we will give patients systemic immunomodulatory agents, but that is kind of a last resort, and it's a very rare occurrence. If you believe that there might be some hormonal impact of this, patients going through puberty may have some, or patients taking contraceptives, it would be reasonable to look into this. If your patient used to have it, once a year, a few times a year, but now they're never ulcer free, that would be one of the evaluations we could consider in this type of population. So moving on to gestation. So a little later on in life, what we see often, not very often, but more often in this population, is pyogenic granuloma. So a pyogenic granuloma is a reactive condition, and it's caused there because of local irritation, which could be plaque and calculus, or some type of repetitive trauma. These lesions typically are rapid onset. They can happen within a few weeks, a few months. And usually we have this nodule that's exophytic. It could either be pedunculated or sessile. It presents as a papule, a nodule, or mass. They tend to keep growing as long as the irritant is there, and they can sometimes be lobulated. In the appearance, this one is more erythematous, but if it's been there for a while, it can look more mucosa colored. We see here in this case, there's bleeding, and sometimes you can even have superficial ulceration of that papule nodule or mass. And what a pyogenic granuloma is essentially is a proliferation of granulation tissue, and there are dilated blood vessels, and that's why it can sometimes have this lobulated appearance. And this increase in the blood vessels is because, and the granulation tissue is that it's basically an exaggerated wound healing mechanism from that chronic irritation. And some of the growth factors we see that feed on that lead to the development of this is vascular endothelial growth factor and basic fibroblastic growth factor. For the gender-specific considerations, what does this have to do with gestation? So again, the elevated levels of estrogen and progesterone are going to promote the production of angiogenic mediators. And we have less endothelial apoptosis, so we have that proliferation of dilated blood vessels. When we have a pyogenic granuloma in pregnant individuals, it's called a granuloma gravidarum, or a pregnancy tumor. This happens, again, not frequently, 0.5% of pregnancies, but it is notable. And it tends to occur during the second trimester, and you can make the connection with what Dr. Histor-Cockrell said about the gestation and the hormone levels and in the second trimester. Similarly, because hormonal contraceptives simulate a state of being pregnant, it can increase the development of pyogenic granulomas as well. And because during menopause, you have lower levels of these hormones, we see them less commonly in menopausal patients. The diagnosis is also through clinical presentation and history, but biopsy is necessary for definitive diagnosis because there are other peripheral gingival nodules that can look like pyogenic granuloma. But if it's in a pregnant patient, your most likely differential is going to be a pyogenic granuloma. Once a patient delivers, we can see a decrease in the size where it regresses, it gets smaller. Doesn't necessarily go away. Maybe if it was really small, it might go away. You still have to do a surgical excision and address that chronic irritation or traumatic factor, but it will get smaller if you're not able to remove it during the pregnancy. So in management, it's surgical excision and address the chronic irritation. If you feel that there's a hormonal contribution that is going to be continuous, then it might be worthwhile looking into that. Moving on in life stages. In middle age, there are other things that we would be seeing more frequently. One of them is lichen planus. Lichen planus is an immune-mediated disease that's type 4 hypersensitivity, also mediated by T lymphocytes. Here are the CD8 cytotoxic lymphocytes that are destroying those basal keratinocytes in the epithelium. And clinically, they present with these bilateral symmetric reticulations and striae. There could be erythema, and there can also be ulceration together with the reticulation. But the most defining feature of lichen planus are those reticulations or striations. And they are bilateral, symmetric, and affect the usual sites, which is the buccal mucosa, the gingiva, and the tongue, as we see in these photographs here. Lichen planus can also affect the skin, so you can have it on the skin and in the genital area. This condition is waxing and waning in nature, meaning people will get a flare where they'll have reticulation and or ulceration and erythema. The reticulation typically doesn't go away, and patients tend to be symptomatic when there is erythema or ulceration. So it will get better with treatment, but a few weeks will go by, a few months will go by, and then they have another flare. So that's the waxing and waning nature. And what can trigger some of these flares, well, there are many things that can trigger some of these flares. So with our gender-specific considerations in the context of this talk, we see this condition more commonly in middle-aged individuals with its peak incidence between 40 and 60 years of age, and that's around the perimenopausal age. It is more commonly seen in general in females. And altered estrogen levels can also increase that pro-inflammatory cytokine, modify those T cell responses, and make lichen planus in females more severe than you would encounter in males sometimes. Of course, this is not totally generalizable. But also females have a higher rate of autoimmune comorbidities. So you have one immune-mediated or autoimmune disease, you're more likely to develop another. There's also, with respect to the triggering, exacerbating factors, as you get older, They may have children, may have a lot of, maybe a caretaker for a family member, as was mentioned earlier today. So there tends to be a higher rate of stress as the triggering or exacerbating factor for these episodes of the oral lichen planus flares. To diagnose it, lichen planus is a clinical diagnosis. There are many other conditions that can look similar to oral lichen planus, both clinically and under the microscope on histology. What you will see on histology for oral lichen planus, it will never say oral lichen planus, it will say lichenoid mucositis. And there are many things that can cause lichenoid mucositis that a pathologist will see under the microscope. So some differential diagnoses for lichen planus is an oral lichenoid hypersensitivity that can be due to medications or dental materials. Lupus, which is going to be an autoimmune disease, can look exactly like lichen planus, both clinically and under the microscope. Graft versus host disease, we would see that in a patient who has a stem cell transplant. And chronic ulcerative stomatitis, which is a very rare disorder, also looks exactly like lichen planus clinically. So it's important to interpret any histology within the clinical context. Do we have bilateral symmetric reticulations with or without erythema and ulcerations in the usual places? Then we most likely have oral lichen planus. To manage this, because it is T-cell mediated, we want to use topical steroids and use that during these flaring episodes. If a patient does not respond to that, we can think of using systemic steroids or immunomodulatory agents for more severe disease. But we also want to identify what things may be triggering or exacerbating their flares. And if hormonal factors are thought to be involved, we want to address those. And because it's
Hi, how are you?
because it's considered an oral potentially malignant disorder, we need to monitor
Because we're listening.
we need to monitor these patients at least once a year to look for signs that may be concerning for malignant transformation. And the last chunk that we're going to talk about is the later stages of life, post-menopausal. We have a few here that are going to show up. So osteoporosis has already been mentioned earlier today, and that tends to be more common in postmenopausal women. And with the decreased estrogen, which is common after menopause, we get increased rank ligand expression that gives us more osteoclastic activity, decreases bone mineral density. And so patients will be, patients who have osteoporosis may be put on anti-resorptives to prevent the osteoporosis, but anti-resorptives can also be treated or used to treat bone lesions in patients with metastatic breast cancer, which is the most common cancer in women. And the anti-resorptives will increase the risk of patients developing MRONJ, right? So treatments for menopause and treatments for hormone-sensitive cancer, like anti-resorptives, can increase the risk of MRONJ. For us to diagnose MRONJ, we need to take a thorough medication history, see which anti-resorptives this patient has taken. Common ones are bisphosphonates, but with the treatment for cancer, VEGF inhibitors can also lead to MRONJ. And then we want to do a thorough clinical examination and a radiographic evaluation. When we have MRONJ, we have exposed bone or bone that can be probed through an intraoral or extraoral fistula in the maxillofacial region that's been there for more than 8 weeks. So here we have this exposed bone on the mylohyoid ridge here of the right mandible. But the patient should also have no history of radiation therapy to the jaws or metastatic disease to the jaws, because those would be osteoradionecrosis or just a bone metastasis. There are 4 stages of MRONJ, 0 being a non-exposed variant where you could just probe it. The exposed variant, and then all the rest are exposed. So stage 1 is when you have exposed bone, no inflammation, no infection, which would be this case here. Stage 2, when you have exposed bone with inflammation and or infection. And stage 3, when it's exposed, but has extensive disease. There might be an extraoral fistula, there might be a pathological fracture, an oral antral communication, things of that sort. To manage this, first off, we start very conservatively, also depending on the stage, with an antimicrobial mouth rinse like Paradex or Hexadine. And if a patient has stage 2, we would want to give antibiotics. If a patient has pain, we can give analgesics. And there's also a protocol of pentoxyphylline plus vitamin E to treat this. Patients who have stage 1 and stage 2, that area of dead bone often sequesters on its own. It's going to come out on its own, but we can do a surgical debridement whenever necessary, or a surgical sequestrectomy and remove the whole thing when we can't just debride. In stage 3, typically that's going to require surgical intervention. Should send it to oral surgeon for that. But what's really important to talk to patients is about preventive strategies. So if your patient has osteoporosis, you should be talking to your patient about this. They may not be on bisphosphonates now, but they may be planned for it in the future. So it's really important to monitor a patient's bone health. If a patient needs to have some type of surgical intervention and they're taking bisphosphonates, depending on the reason they're taking it for, sometimes we can consider a drug holiday. It's harder to justify drug holidays when a patient's taking it for cancer reasons, because their cancer tends to be more important than MRONJ. And whenever feasible, obviously in talks with their gynecologist, hormone replacement therapy may mitigate the risk of developing this in postmenopausal women. The last thing I want to talk about, I know we're running short on time, is burning mouth syndrome. So like Dr. Hister-Cockrell was talking about, women tend to take on a large burden of psychological and social burden within families and within society. And when we have this chronic stress and this chronic worry and mental health issues also that are not addressed, it can lead to chronic pain disorders. And one chronic pain disorder that we encounter in the orofacial region is burning mouth syndrome. It's an idiopathic chronic pain disorder, and it's thought to be multifactorial. There's some neuropathic component to this, but basically it's a maladaptive process where you're feeling pain when there's no good organic reason, right? There's nothing wrong with the tissue in itself to justify why you're having this pain. So it's an altered central nervous system pain processing. And there is a very strong psychological contribution. We tend to see this more commonly in patients who have anxiety and depression. And what patients will report is a burning sensation of the tongue, the lips, the anterior hard palate. Those are the most common areas. But clinically, there are no oral mucosal abnormalities. Some patients will also report dry mouth or altered taste, dysgeusia, along with the burning sensation. But the clinical exam is entirely within normal limits. This is more common in older individuals over the age of 50, which falls within our postmenopausal, and it is a lot more common in females than males. There is decreased estrogen. It's thought that it can alter neurotransmitter regulation and pain perception, and maybe that's why we see it more commonly in females. That's not totally established yet, but decreased estrogen has been associated with that impaired modulation or regulation of nociceptive signals. We also, like I previously mentioned, have higher rates of anxiety and depression in women, and psychological component is very strong in burning mouth syndrome. It is a diagnosis of exclusion. There's no test you can give someone to tell them they have burning mouth syndrome. You have to rule out all the other things that can lead to burning symptoms whether that's local or systemic, like having the dry mouth or having candidiasis or, any nutritional deficiencies, all of those things that may present with oral burning, you have to exclude that first to be able to make a diagnosis of burning mouth syndrome. So it's based on your clinical findings and laboratory investigations to rule out these things. And the management, because it's multifactorial, there's a large psychological component, is going to be multidisciplinary. Pharmacologically, because it's a central altered processing, we frequently use antidepressants, benzodiazepines, or other CNS altering medications. For patients who have low levels of pain, maybe this is the beginning, sometimes we can see some benefit with alpha lipoic acid or topical capsaicin. But more often than not, people are going to end up being on some type of systemic CNS altering medication. For the psychological component, that's very important to be addressed as well. And cognitive behavioral therapy has been reported to be helpful in patients who have burning mouth syndromes, and they're going to have less chances of getting better if we do not address these underlying psychological factors like anxiety and depression and other chronic pain conditions. Because if you have one chronic pain condition, you're also more likely to develop another one. And because there is this thought that maybe altered estrogen levels can have a influence on the development of burning mouth syndrome, it may be worthwhile investigating those hormonal considerations wherever it's applicable. And that was it for the oral conditions.
On camera.
So I'm going to stop.
There.
Thank you so much, Dr. Tavares, and thank you as well, Dr. Hister-Cockrell, for your wonderful presentations. At this time, I'd like to open the floor with the last couple minutes we have. Are there any questions for either of our presenters today? We have time for at least one.
Let me just read this last slide. Can you just want to just see our slide? I would like to do just a special thanks to Dr. Dar, Dr. Tavares, Dr. Villarreal, Dr. Soto, Dr. Kajimoto, and in special the UTESCA Marketing Department. I place in here the first article that we talk about if somebody would like to read, and the second one. And it was a teamwork, so I'm very grateful, and I hope to my students that are about to graduate that they will take all this information to their practices. That's a lot of valuable information here.
Thank you all for your attention. I know we all have to get back to clinic.
Yes, so Taylor, if you could just share the last closing slide for me, please, and we can wrap up the session for today. So yes, thank you all again for joining the 25th Dent Echo. We hope to see you again in the future. Please complete the post-session survey using the link in the chat that Taylor just shared. We hope to see you again in May, so not next month, the following. And everyone have a wonderful rest of your day and week. Thank you so much.
Thank you, everyone. What a wonderful presentation.
Thank you very much.